So I'm actually from New Orleans, and as Raul said, I went to LSU Baton Rouge, went to LSU New Orleans, and now I'm in LSU New Orleans for residency. So as you can tell, it's haven't moved very far away from the home center here. So basically just objectives, I just want you to take away with this. I mean, it's a great opportunity to build apps, but if you don't really, I guess, understand what diabetes is or why we need to treat diabetes or take care of diabetes, I think it's a huge issue, obviously. So objectives of this talk is what is diabetes. So when you walk out of here, you'll have some type of at least macro view of what diabetes actually is. The economic impact of diabetes, why is it so important to take care of, why is it so important to track and treat and keep people compliant with their medications. Discussion of some of the complications of diabetes, things that can happen, why do we do some of the screening tests we do every year or twice a year, 4 times a year, whatever. Discussion of type 2 diabetes treatment modalities and diagnosis, and applications at the end. We'll talk kind of give you some brainstorming of applications that you could use with diabetes and other diseases in mind, not just specifically. So basically, what is diabetes? Anyone in here know someone with diabetes? I'm sure probably everyone. This is South Louisiana. Everyone knows someone with diabetes. I actually, in my clinic, every day I see someone with diabetes. Not newly diagnosed, but just carried on from before. So basically, diabetes is a group of disorders characterized by the inability of the body to regulate blood glucose levels. So basically elevated glucose levels in your body at all times. So with that, you've created now a dynamic. It's type 1 and type 2 diabetes they've thrown it down to. Type 1 diabetes was previously called juvenile onset diabetes, but now with the epidemic of childhood obesity, it's now pushing the limits of type 2 diabetes, right? Because that was a distinction. Type 1 is juvenile, type 2 is adult, but that classification has kind of just disappeared. So in type 1 diabetes, results from autoimmune destruction of the insulin-producing cells inside your pancreas, in islets of Langerhans. In type 2 diabetes, your pancreas basically doesn't make enough insulin to keep up with all the sugar in your blood, or the body becomes insulin resistant. So basically, or it's a combination of the two. So it just doesn't use insulin correctly. So with that, what is insulin? So insulin is a hormone that your body uses to basically, it's a gatekeeper that your body releases from your pancreas to allow sugar, glucose, into your cell, because all your cells have a basic metabolic function, and depending on, it could store it, or also it could just use it as an energy. And insulin, as you can see in the picture, in a healthy individual, you'll have a release from pancreas, just like we had some great cookies back here. Well, you eat them, your body digests. All of a sudden, you have this rush of sugar in your bloodstream, right? And your body's like, oh man, what the heck, what's going on here? We've got to do something about this. So it releases insulin from your pancreas. And in a healthy individual, you'll have these little cells, and proteins, actually, peptides, will go around and bind to insulin receptors on cells, and it'll allow the glucose to enter the cell, right? For storage, for use as energy, whatever. Well, in type 1 diabetes, as you can see, you're missing a factor here. So in type 1 diabetes, you're actually missing the insulin. So your body has lots of glucose hanging around, floating around and everything, but there's no way to allow that glucose to enter the cell. So that's why, anybody have a crazy idea how we treat type 1 diabetes? We give them insulin. That's the key. We've got to make this simple for us, all right? We can't handle that much. So with type 2 diabetes, and the reason why I want to focus more on type 2 diabetes, because 90 to 95% of the cases in the United States are dealing with type 2 diabetes versus type 1. And just kind of going back a little bit, type 1 diabetes is usually found earlier on, so that's why the juvenile name is still kind of tagging along with that, because type 2 diabetes also takes a long time to occur, and usually it's later in life and other factors. So with type 2 diabetes, you have the insulin. Your body still can create some insulin, sometimes not enough, but your cells are actually desensitized to the insulins, right? So you need more insulin to keep getting that same reaction you did before. So hence why we use medications, weight loss, lifestyle changes, or we just give them insulin in the end, so that could happen. So you allow that insulin binds to that receptor, and then glucose will be able to enter the cell. So just kind of, and this is why I really want to focus on this, the cost of diabetes. And it has risen so much since the 1980s, 90s, and 2000s. Actually, as you can tell, well, you can read, it's epidemic proportions now, with 29 million Americans living with the disease, and an additional 86 million in 2012, up from 79 million in 2010, are thought to have pre-diabetes. So estimated costs in 2012, including indirect costs, direct being 176 billion, indirect being $69 billion in indirect costs. So direct costs being emergency room visits, medications, going to the doctor, yearly, twice a year, 3 times a year, blood tests, and indirect being like absenteeism, just not being able to perform at work, unemployment because of complications with diabetes or other things like that, or you just can't, some people are wheelchair bound because of amputations. It's hard to perform at some jobs whenever you have that kind of issues, and roughly 1 in every 10 healthcare dollars in this country is spent on diabetes and its complications. So basically, this was in 2012. It's $245 billion was spent, and as you know, the United States has 17.5% of our GDP is spent on healthcare. And as you can tell, when you spend $3 billion, that's actually 2014 money. So it's a pretty good chunk of change, if you will. And this is kind of the hammer in the point if I haven't already. Among adults with employee-sponsored insurance, average per capita spending with those with diabetes was $15,000, about $10,000 more, over $10,000 more than those without diabetes. This is actually a graphic from the AMA release from Healthcare Costs Institute. So with that, how do we take care of type 2 diabetes? Now, there's a lot of overlap type from 1 and 2, but I'm just going to, like I said, we're going to focus on 2 because of the high incidence. Who should we screen? Should we screen everybody? Like, just show up, everybody gets a hemoglobin A1C or fasting blood glucose level? Well, the thing is so the experts really don't know either, to be honest with you. So this is actually, if I remember correctly, from the ADA, and there's also the United States Preventive Task Force that also have some guidelines with that. So with this in the ADA guidelines, basically anyone with a BMI of greater than 25, so BMI is a body mass index. It's calculated by using the weight and height of the person. Over 25 is considered overweight, right? So once you're 25, you met part 1. So with any one of these other stipulations, like family history, like your mother had diabetes or your father has diabetes, or a member of an at-risk group like the Native American population, or you automatically get screened right off the bat if your BMI is greater than 30, which is considered obesity. So just kind of, I mentioned prediabetes twice now. So prediabetes, also known as borderline diabetes or impaired fasting glucose, impaired glucose tolerance, it's all pretty much synonymous. It just depends on the test that you took when you were diagnosed with it. And honestly, all it really means is that you're at a higher risk for developing type 2 diabetes and other cardiovascular disease. But the thing is just because you're pre-diabetic doesn't mean you're going to be diabetic. You could still go, there's retroactive there that can still happen. Some of the symptoms with diabetes is more of like a book case. It's increased thirst, increased urination. So if you're thirsty all the time, don't think you have diabetes, but look into it, talk to your physician. But increased thirst and urination, fatigue, you're just tired all the time. Increased time healing. So you'll have some people will come in and have wounds on their feet and it'll just stay there for weeks, and say, oh, it'll stay red with the erythematous and it'll never heal. This was one of the issues with diabetes. Erectile dysfunction, blurry vision, unexplained weight loss, and neuropathy with numbness, increased pain, tingling in your feet, or lower extremities, and also you can get in your hands later on. So basically, how do we diagnose diabetes? So now, a fasting plasma glucose level, and as you can read, these are the numbers. A fasting plasma glucose level is whenever, usually you do it in the morning, after you have not eaten anything or drank anything in over 8 hours. It's fasting. You go ahead and they take a lancet and they poke your finger and they check your blood sugar, see what it was on the glucometer, right? And these is, you basically just line it up. If you're pre-diabetic at 110, for example. The thing is you have to have a confirmation test too, either the same day, later that day with the same type of test, right? Because you don't want to start mixing tests like fasting plasma glucose level and an A1C. Well, now it's not all in sync quite yet. So oral glucose tolerance test is actually not used as much anymore with the advent of the hemoglobin A1C, but it's still used. Basically, you take a little shot of glucose, basically a little shot of sugar, also in a fasting state. It's 75 grams. You drink it. Then 2 hours later, they'll check your blood sugar. And then same situation, you have the type 2, you're diabetic at over 200. And lastly, hemoglobin A1C, which is actually a beautiful test. Ease, the reason why it's beautiful is because it doesn't matter if you're fasting or whatnot. So A1C is basically, you have your red blood cells, which their lifetime of one red blood cell is about 120 days. So hemoglobin A1C percentage level is your average blood sugar within the last 2 to 3 months, right? So inside those little red blood cells, you have hemoglobin. And hemoglobin basically carries the oxygen to all the cells in your body. Well, if you have a lot of sugar in there at all times, they become glycated. And with that, with this blood test, you literally just draw your blood, doesn't matter if you're fasting or whatever, and this is a percentage of the glycated hemoglobin inside your blood. And so with that, as you can tell, less than 5.7 is normal. Pre-diabetes is 5.7 to 6.4, and also type 2 is obviously greater than 6.5. Now with that, you can also track, so say somebody comes in right now and their hemoglobin A1C is 5.8, whatever. You get a confirmation test. Well then 6 months down the line when they come back, say, oh, it's 5.9. Okay, well you haven't been, we talked about lifestyle changes and weight changes and things like that, so you can really tailor it to personal medicine once you see that happen. Some of the complications of diabetes, why is it so important? Hospitalization rates for people with diabetes are 1.5 times higher than those among adults without diabetes. Cardiovascular death was 1.7 times higher. In 2011, diabetes was listed as the primary cause of kidney failure in over 40% of new cases of failure. So with treatment, most of the time it's a pretty treatable disease. It's actually very treatable. So the goal we have whenever you come in and you're diagnosed as diabetic is our goal is to have you at a glucose level, sugar level, whenever they take your little finger stick and they check your glucose, between 90 and 130 before you eat, right? And a hemoglobin A1C, which we talked about, the glycated hemoglobin, of less than 7%. And so how do we do that? So what's the first step? Well, usually the first step is always diabetes education. Education, 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 because a lot of people, first off, don't have a clue what diabetes is, have no clue what to eat. I mean, do you know that Coca-Cola, or a can of Coke, has 40 grams of sugar in it, 40 carbohydrates, which is 13% of your daily value of carbohydrates, and 140 calories. Well, you get somebody who drinks a Coke for lunch, dinner, before they go to bed, I mean, you're already at 50% of your daily carbs, and you didn't even eat anything yet. Weight reduction, lifestyle modification, also cardiovascular risk factor management, and you can put surgical therapy along with that, like the lap band, gastric sleeve, gastric bypass, which I'll touch on a little later, and of course pharmacologic therapy. So with pharmacologic therapy, first-line treatment, usually, I say usually very broadly because it's not always, a lot of people use metformin for a number of reasons, because it's cheap. People take it, it's like twice a day. Glycemic efficacy is really good. It can usually drop that A1C level we were talking about at 7. Remember, we want it less than 7. With taking metformin and lifestyle changes, you can usually drop the A1C between 2 and 4% if you're very compliant, obviously. With that, if basically in 3 months, if your A1C or your sugars are getting higher with symptoms, et cetera, then some clinicians will try dual therapy, triple therapy, and basically if all else fails, you'll initiate insulin therapy. And obviously, if someone comes in off the street, never been diagnosed as diabetic with A1C, as you can tell, at 9, these super high glucose levels, and you just usually start insulin right off the bat. This is a very exhausting list. I'm not going through all this, but I just wanted people to have everything, all the developers to have everything on a slide. So when we refer back, this is pretty much all of the pharmacologic treatments of diabetes. There's actually one coming out. It's inhaled insulin and things, but besides the point. There's a lot of, the most popular ones are also on here, like metformin, glipizide, glyburide. There's also some newer guys on the street, SGLT2 inhibitors like Evocana. You've probably seen a commercial. A lot of these are just coming out. Using different techniques of basically lowering your blood sugar. Like the SGLT2 inhibitors actually block the reabsorption of glucose in your kidney, so you literally pee out the glucose. So just a quick list of therapies with insulin. Once we start the insulin therapy, basal insulin is usually kind of the sequence of events. So lifestyle modification didn't work. Metformin, other drugs, dual therapy didn't work. Well, now we're going to start basal insulin on you, right? So basal insulin means it's basically once-a-day therapy. So glargine and detamers are two different types of insulin. These are Levemir and Lantus, are the brand names. And the reason why we use it is because you give it once a day. It's very convenient, and it'll last throughout the whole day. Usually give it at night. Also, there's other types of insulin like MPH, which lasts between 10 and 16 hours usually. That's why you give it twice a day. Intermediate insulin, we don't use it much in the outpatient setting, more than the inpatient if needed. And of course, after the basal insulin fails, like if you're taking Lantus, whatever, once a day, twice a day, now you move to the prandial short-acting. So that means you're going to start taking Humalog or Novolog right before you eat to help control your blood sugar. And these are, now you're starting to get onto the end of the spectrum where this is a super severe, like a super severe case of diabetes. Just to touch on the surgical therapy we kind of talked about a little bit. So one of the things they do, this is actually much different. There's a gastric sleeve, gastric bypasser, which are pretty invasive surgeries. A lap band, y'all may have heard of the lap band before, which is a pretty much a plastic piece with a coating with some liquid in it that goes around the upper part of the stomach, specifically the cardia fundus area. But the whole idea of it is to create this pouch. It squeezes your stomach. It creates a band on top of this, right? So now you've made a smaller space that the food can go into. So it gives your body time to know that you're full, right? Because satiety takes time. So when you're in there, you're eating hamburgers or whatever, you can eat and eat and eat, but if your body doesn't know it's full, it's not, you're not going to have that feeling. So that's what the idea of the lap band was. And as you can tell, this actually is under the skin, and it's adjustable by the surgeon. So some of the complications, once again, long list, but I just wanted to have everything there for the developers. So basically, we do yearly screenings, sometimes annual, biannual on other things, and quarterly on other things, depending on what it is. So yearly eye screenings to help prevent diabetic retinopathy. Yearly foot exams and neurologic exams to help prevent neuropathy. Annual screenings with microalbuminuria and things like that. And basically, the main thing is weight loss, nutrition counseling, diabetes counseling in the most part. Because if you can control your weight, you control a lot of the symptoms that you'll get. Diabetes, if you control, you can actually live a very good life. The problem is whenever you become uncontrolled for a long time and your body starts to hit these huge microvascular issues and macrovascular issues is when the problem occurs. And of course, stop smoking, because people still smoke, and that's just my pet peeve. I don't see how people smoke anymore. It drives me crazy. But the vaccination also, you keep up to date on your flu shot, pneumonia shot, Tdap, all those, because you want to prevent that infection from happening, because diabetes does affect your healing rate. So just kind of why am I here? This random diabetes talk, I know. But so I'm a web developer, kind of do a lot of that stuff still, and I've learned to do some Objective-C in the past few years, doing with iOS. The reason why I chose iOS is because I had an iPhone. I didn't want to buy a new phone. So with that, I've done some medical apps, some games, things like that. But as I became a resident, I just don't have time to do the programming anymore. So I mean, I have lots of ideas, I just don't have the time to do them. With that, I'll kind of jump into the app portion. So the diabetes monograph with Boston Children's Hospital, which was obviously produced in Boston Children's Hospital. This is just kind of a picture of the app itself. Just kind of going over like some of the medications we went over. Like a lot of these are, actually there's a lot of diabetes medications on here. CV, comorbidities, things like that. If you notice though, the test reminders, A1C, like you're supposed to get them, remember we talked about twice, actually I don't know if I mentioned it, but quarterly if you're not compliant, if you're not controlled, or biannually if you're controlled. So this is important. A1C of 8.6, goal of less than 7, things like that. Just moving on, so this next part is the idea is you have to have a problem usually before you can create an answer, right, the solution. So the question is from our standpoint, in a clinical standpoint, what do we need, what would help us, right? And at LSU, we actually use 3 different EMRs, which I'd like to think I'm a techie, but maybe not as much. But it's pretty cumbersome whenever you're trying to move around and all this. So a standardization would actually help a lot. So the next portion is just some ideas that to get people's mind moving a little bit. Some of the developers, what would help us out? So just starting from the top. So some of these may exist already. I know personally in my clinic, they don't. I don't use them. So this is all new from mine, but I know there's some other third parties out there that have something like this. And actually, I think the speaker before mentioned them. So connection between devices, right? So glucometer, it gives us a blood sugar to the EMR or to the nursing EMR or whatever it is, because it's important to see that if you're seeing a guy who's been compliant with his medications and all of a sudden, for 3 weeks, he's like, in the 120s, and all of a sudden he starts spiking with these blood sugars in the 300s, 400s, 500s. And you're like, wait, what happened? This should be a red flag for us to prevent it from him coming to the emergency room, right? Because now if he goes into DKA, which one of the acute complications, which was DKA, is still fatal. Granted, we use insulin now, and I think someone won the Nobel Prize in the early 20s for finding insulin, using it. But the thing is this is a very, very detrimental complication. So if we can prevent him from coming to the ER, that's going to save a lot of time, and everyone's going to be much happier. So when you see a red flag like that, you can have someone call him like, hey, are you out of your insulin? You know, you're taking it correctly? What happened? You know, you went to Fiji? I don't know what happened. But anyway, that's one issue. And the same thing goes with nutrition, weight loss, weight gain, exercise data, food data. Someone actually just spoke about that, which is amazing because now you're able to find that trend of, are they losing weight? Are they gaining weight? You know, what's going on? Why all of a sudden you gain 5 pounds in the last 3 days? You know, what's going on? I don't know what happened. Let's see if you can stay on top of these things. They become less of an issue in the end. Same with exercise, with the wearable data. In my perspective, I think it's the best thing ever because there's another personal story. I had a guy come to clinic. His blood pressure was 167 over 110. He's on 3 blood pressure medications. So he's like, Doc, I took it yesterday. He has a blood pressure machine at home. That's not connected to the EMR, by the way. He's like, I took it yesterday. It was 115 over 9, you know, went over 82 or something like that. And I'm like, oh, wow, you know. So now, but if you think about it like this, is that this is a new problem because why would I start or up one of his medications, right? So now I'm upping like one of his ACE inhibitor, right? So now he has to spend more money on this ACE inhibitor that he doesn't even need most likely because it could be white coat hypertension. I mean, it's kind of, you know, the question is if you can prevent it from happening in the beginning, right? So the thing is, and 20 years ago, I don't know if this has happened as much, but people did recognize white coat hypertension. But if there's a data that you can have at home, you know, your blood pressure every day at 12 o'clock at your house is 120 over 80, which is beautiful. And then now you come to us the next day and it's spiking in the 160s, you know, what's going on? Obviously, do you really need more medication or you just need, you know, stress talk or et cetera? One issue that I fall into, another personal story in my clinic, is understanding when to take medications. We had a great view from the Duke pill box, which is a great idea. And kind of just to go along with that, one thing I was thinking about is even starting videos. Because, for example, when you take a drug called Synthroid, which is used for hypothyroidism, right? Does anybody know when you take Synthroid? You take it once a day. If I just told you that, like I told a patient, you take Synthroid once a day. Well, do I take it with lunch? Do I take it, you know, 5 a.m.? You don't know. Well, the thing is you're supposed to take Synthroid 30 minutes before you eat breakfast in the morning, right, for its effect. But the thing is a lot of people don't know that or they miss that whenever you're talking to them. So the thing is you could have some type of video or animation or whatever it is to show people how to properly take these medications. And actually, I was talking to one of the professors from Tulane just a while ago talking about insulin, taking insulin correctly and things like that. Because there's a special way you need to take the insulin. I mean, and certain depth you have to go, certain, you know, different things like that. Are they really taking their insulin correctly? Are they, you know, where's it coming from? Is it old, you know, et cetera. Some other, from the clinician side, some of the things that would help us is that you've seen that a list of data. So you can imagine some of our patients have 20 medications, right? We don't know, granted it does say when they started them sometimes and things like that or when it's changed, but if you can imagine having a whole history of medicine, like their medication data, right? So when did, for example, you were diagnosed with diabetes in 2005, right? That's when we discussed, you know, nutrition, diabetes education with you. Well, in 2006, you started taking metformin, right? Well, in 2007, you upped your dose of metformin to 1,000 milligrams twice a day. Well, in 2011, you started taking Lantus. You see what I'm saying? So you're able to see when the doses were changed, what medications they're on. So you can create this basically a graph of just all this going on. So it helps us understand that, oh, you know, why is he still on metformin? What's going on here? Why didn't he change to this? You know, there's multiple different answers you can have. And then also you can graph that if you think about that. You can graph it against hemoglobin A1C or weight distribution and different things like that to see exactly, was he controlled? Was he not controlled? Why did he switch Lantus dosing? You know, why did he switch to 40 to 45 every day, et cetera, 45 units? Another just random idea, this is not dealing with diabetes, was radiology, tiling the X-rays and CT MRI imaging studies with FHIR into the actual into the actual EHR. It just takes time because if you can imagine like a clinician seeing all of the X-rays or CT scans or MRIs for that encounter or for all the encounters, it doesn't matter where. But the thing is, if you can see a preview and easy access into that X-ray or into that CT scan, because now no matter what EHR you take, it takes, you have to, there's about 45 different clicks to get to the x-ray and then the report, right? I'm sure some people share that same, which it doesn't sound ridiculous when you have, and when it's 5:30 in the morning, you have 20 patients to see, and you're going through all these charts and trying to see x-rays that came up, or EKGs with, heart, everybody's chest pains, you have to see all the EKGs and all the troponins. I mean, you're basically decreasing your time by massive amounts. If you have previews right there, it's just easy clicks, boom, 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 you're done, or, move to the next patient. Same thing with the micro ideas, just all the micro labs from the past. Same situation, you just graph those against, in 2010, he had Pseudomonas infection. In 2011, he had a UTI with E. coli. You see what I'm saying? So you're now creating a history of this patient. Instead of having to go back and just read lines of code, basically, you're actually creating a graphical model for the clinician or for whomever. And of course, billing, coding, diagnosis, et cetera. I'm sure that's a whole different talk. But mainly, our aspect of with the going back real quick, just to understand the medication, how to take the medications. A lot of things, I think they were right on with the app they were talking about. Essentially, first, what I think Josh talked about first, where the CV risk data and risk stuff like that, talking about the blood and the lab results. If you can make that look, or whomever can make that just look aesthetically appealing, just helpful. Like, what is, just because I have a LDL of 110, what the heck does that mean, or I have a TSH of 2.7, what does that mean? Okay, well, the reference range, it's in reference range. I guess I'm good. But really, if you think about it like that, I get calls from my parents or whomever, which I left most of my parents' stuff out of here because I figured they were the younger. But the thing is, they call me about, like, oh, I got a blah, blah, blah of 2.7. I'm like, oh, well, okay, well, that's good. Are you having, symptoms and stuff like that? But I think there's a lot of education that could, there's a huge opening for education that could be done to help patients understand their data and have access to that.